some of the health systems have good data. You're just not giving it to the payers. They're publishing it within their own directories. They're not perfect, but they're a whole lot better than the payer directories.
Why do you think they have great data and they're just not giving it?
Because they're solving for two different jobs.
Hey, it's Nick and Mitch, and this is Provider Data Dorks. Our guest today is Ron Urwongse from Defacto Health. They get into why good data gets stuck in the wrong department, how a single dropdown caused thousands of errors, and what 150 health plan directories actually reveal about accuracy.
We're now connected to 150 payers. And while every single one of those payers has inaccurate data within their directory, where they agree and where they disagree is incredibly informative. You've got 11 out of 12 payers who think that Dr. Smith is at an address and has his phone number. It's probably right. And there's actually quite a wide range of accuracy. Middle of the range is still kind of around the 50 to 60%, but you have high performers who are creeping up to or breaking through the 70% ceiling. And then you've got some of the low performers that are unfortunately at the 30 or 40%.
Why are the bad directories bad?
Because of all sorts of reasons.
Okay, what's the best advice you've ever gotten?
The best advice that I've gotten is to fall in love with a problem and not fall in love with a solution. I know it sounds weird to love a problem, but you have to fall in love with the problem.
Today we were joined by the co-founder of Defacto Health, Ron Urwongse, and man, does this guy know provider data?
I mean, I was nervous for the conversation. I consider myself a provider data dork, but just hearing how health plans in the space talk about Ron and the Defacto team, I didn't know if I was going to be able to hold my own.
Yeah, and I mean this in the most complimentary way, but King Dork. The guy really, really understands the space. It's very clear why the plans and providers that he work with love him and the company. We got into a lot of really interesting stuff today. I thought what was really, really interesting was how he was able to call out some of the key insights as to what makes plan directories more or less accurate. And he was able to showcase or talk about, hey, I've seen that the more accurate plan directories have these characteristics versus the less accurate ones have those characteristics. Funny enough, the more accurate ones look more like your high school math score, which is still not that great.
Still pretty poor. Still pretty poor. I think you're talking to someone that really understands the problem when they can simplify it. And he did a fantastic job of really starting with, if we start with these upstream issues and solve it there, the downstream pieces get simpler.
Yeah.
And his ability to walk through that was something I really enjoyed. And then wrapping that into the current environment with what CMS is doing with directories today in this space and how we're at this point where maybe we are getting closer to like a plaid for healthcare that we can build on top of to provide value to the ecosystem.
Yeah, which is, kind of in a similar vein as to what Defacto actually does today. And so one of the interesting things I thought, Ron called out is, hey, I don't see this as competitive to Defacto. In fact, if CMS is able to pull this off, that's great. A rising tide lifts all boats. And there's so much more that we could do with this data. This is just the beginning. So tune in. I think it was a really interesting conversation. I think everyone's going to enjoy it. Let's dork out.
Welcome to Provider Data Dorks. I'm Nick Helfrich.
And I'm Mitch Gorodokin.
Dorkin.
We started this podcast because one of the most important problems in healthcare is also one of its most complex, provider data.
You guys know it now, but provider data is the invisible backbone of healthcare. Without provider data, you can't pay claims, see members, work with patients, directories are a mess, network adequacy becomes a problem. It's the hidden corner of healthcare that matters the most.
And yet most organizations are still working out of siloed workflows, disparate vendors, manual processes, spreadsheets. There's got to be a better way.
Yeah, absolutely. Each week, we're going to talk to leaders that understand the problems, maybe created the problems, but know how to fix them, want to fix them, and our fellow provider data dorks with Mitch and I.
You're going to leave with sharper instincts, a clearer picture of what's at stake, a deeper understanding of the data behind care, and most importantly, the solutions that our industry's leaders are working on. Today, we got Ron on the show to talk about it. Ron, thanks so much for coming.
Thank you. This was great. Ron Urwongse is a co-founder of Defacto Health, a company that aggregates and integrates provider network data sets. He previously led innovation and strategy at CAQH, where he launched CAQH's provider directory and endpoint directory solutions. His 16 years of experience in healthcare technology includes managing products and infection surveillance, patients self-service, and health insurance exchanges. Ron holds an MBA from the MIT Sloan School of Management, as well as a master's and bachelor degrees in information systems management from Carnegie Mellon University. Thanks for joining us today, Ron.
It's great to be here.
Well, Ron, I got to say, of all the intros I've heard, that's one of the provider data dorkiest ones.
Pretty dorky.
So, Ron, you've obviously you've been in our space for a while. Obviously, leadership positions at CAQH, as well as being the founder of Defacto Health, where you're focused on this problem really acutely. Can you talk to us a little bit about what you guys are doing at Defacto specifically around provider data?
Yeah, so back in 2021, CMS released some regulatory requirements on the health insurers, mandating that they publish patient access APIs and provider directory APIs. So having been at CAQH and being very interested in both interoperability and provider data, it was just right up my alley and my co-founder's alley, TJ at the Garage. We were both provider data product managers at CAQH. So we both launched a couple of the solutions and managed all the provider data solutions there. In terms of the regulatory requirements and the APIs, the data is super valuable. I mean, there's data about all the health insurers' provider networks, or if you said another way, it's all the health insurance plans all the healthcare providers accept. So we thought somebody's got to stand in line to request access to these APIs, aggregate the data, and make use of it, because we knew there was a lot of value and a lot of use cases around that data. So everything from consumer use cases, being able to find in-network providers, shopping for the right MA plans, provider-facing use cases, in-network referrals, all the rest. So we just needed to get our hands on the data so that we could make the most use of it.
It sounds like to really get that data in the right spot, you're going upstream. I think too often we're downstream trying to solve the solution with the downstream problem that isn't going to get us there. Why do you think going upstream needs to be that place to transform provider data and provider data operations?
I feel really strongly about going upstream, both on the payer and the provider side, because if you're cleaning it up ex post facto, you've got lots of parties who are going to be exerting the same types of effort to clean it up multiple times, and maybe they're getting it wrong. And it's lossy because some data is being published, and then you've got to run some analytics and transformations downstream. It's better if you just clean it upstream and it's there and complete and accurate for everybody. But I think that does require, and I'm sure we'll get into this a little bit more, some type of industry consensus in terms of what accuracy and completeness means.
Mm-hmm.
So, Ron, you have a really unique view on the market, looking at pretty much all public-facing directories. What are some of the key things that you've noticed about these directories, maybe from an accuracy standpoint, or how providers or members are interacting with those directories that maybe you didn't expect?
So, having talked to a lot of payers about their own provider directories, and they're all running their own secret shopper audits, and CMS is running some secret shopper audits on them, and they're all seeing them. There's some consensus among the payers that, well, everybody's not doing great. They're all within a certain band of accuracy. What I realized after having looked at 150 payers' provider directory APIs and their data, and doing our own secret shopper audits and algorithmic-based scoring of the data, is that there's actually quite a wide range of accuracy. So, middle of the range is still kind of around the 50 to 60%. And, we can get into the methodology if we need to go into the details of it. But you have high performers who are creeping up to or breaking through the 70% ceiling. And then you've got some of the low performers that are unfortunately hit the 30 or 40% because of all sorts of reasons.
70%, that sounds like my high school average.
99 percentile.
Can we get into
that
would be really high on a curve for me. There was no curve. One of the things you talk about is the algorithmic range and scoring. I'd love to scratch into that. I mean, it's a problem you've worked with a ton. So obviously you're building algorithms that matter in this space and let you get into that upstream problem so you got the appropriate downstream solution. What's most important to you as you look at scoring this data?
Getting as many sources as possible. I know that there have been previous efforts in the past to aggregate payer directory data and to, use consensus scoring. But in the past, when that was done, there weren't enough participants to be able to come up with a good enough score. We're now connected to 150 payers. And while every single one of those payers has inaccurate data within their directory, where they agree and where they disagree is incredibly informative. You've got 11 out of 12 payers who think that Dr. Smith is at an address and has his phone number, it's probably right.
It might be his address.
If only one payer thinks that Dr. Smith is at an address and it might be 20 miles away from the one that 19 out of 20 think is at an address, then maybe that one's not right.
Ron, you talked a little bit about, how you're actually scoring the accuracy of these directories, and I think it's a pretty complex, scoring rubric. Can you talk a little bit about how you actually determine that this is, 50, 70, or 30% accurate?
It's just some basic arithmetic. So taking as many sources as possible, seeing where they agree and where they disagree. It gets a little bit more complicated as we try to weight different sources and as we're bringing on some novel sources in addition to the payer data.
Yeah, that makes sense. So we've talked about upstream, and it sounds like by upstream, you really want to get as many as possible and then score it against an algorithm. I love that concept of, hey, if 11 of your friends are saying that that's what the flavor is, that's the flavor. What's the downstream impact of bad provider data?
Oh, where do we begin?
We could talk for a while here.
Yeah. We should always start with the consumer or the patient because that's why we're all in the business and why we're doing what we're doing. It's just so hard for patients or consumers to find the care that they need. We've seen all of the headlines and some of the Senate committee hearings about this, but when an individual is trying to find care and they start in a payer's directory, they often have to go through 10, 20 different phone calls until they find a provider in network who's actually at the address that they're targeting and who can give them an appointment within some reasonable time frame. So, wouldn't it be great if you could shortcut through all that, figure out who's where, and then finally who's available? That would be amazing to be able to do that.
That one hits close to home. When I moved back to St. Louis, I wanted a primary care provider, healthy adult, wanted to make sure I was on the right track. Everyone I called was out of network, had to go through this directory, and I ultimately was able to finally book an appointment with a provider. And I got there and I'm looking around and I'm like, there's no families here. There's no younger adult males here. It's a lot of older adults. And I had booked my primary care provider visit with a geriatric physician. So I had to switch doctors, but that was something I definitely saw, and the directory wasn't calling that out for me.
We hear a lot about surprise bills, and when our insurance recently changed our company, and when the New Year's flipped, I got a pretty surprising bill from one of my healthcare providers, and so it's a pretty shocking experience. So obviously it hits the consumer pretty deeply, but how about how is it impacting some of the plans or even provider groups that are leveraging this data as well?
So on the payer side, I know that the focus is really on the regulatory compliance, and we've seen first a trickle and then a wave of regulatory and now legislative requirements. So everything from the No Surprises Act to previous Medicare Advantage assertions around how accurate data should be, some of the secret shopper audits they were doing. I think the most recent ones that we're seeing, there's an MA plan finder rule where for the Medicare Advantage plans, they have to publish their directory data in an interoperable way so that CMS can query it and ingest it and present it in their plan shopping workflow. So that, I as an MA consumer, if I'm shopping for an MA plan, I want to make sure my preferred providers are in network. So if CMS can get all of that data directly from the MA plans, they're able to offer that type of search workflow for them. So that's the MA Plan Finder rule, and that's going to hit, I think the MA Plan Finder new version of it will be released in October. So it's a very compressed time frame for payers to be able to make the right data available. So, they've got some efforts ahead of them over the next several months. The second one that just recently came out was the Real Health Providers Act that was signed into law as part of the most recent Consolidated Appropriations Act. That's been in the works for a little while. The new thing about that, I won't go through all the details, but the new thing is that MA plans will be required to measure the accuracy of their directory data and publish it on an annual basis. And so it's going to require HHS, likely CMS, to assert some type of or prescribe some type of methodology around measuring the accuracy of their directory data. And so if everybody is subscribing to the same methodology, publishing it, then individuals will be able to compare MA plans based on not only, hey, these are the providers that I want who are in network, but this is how accurate these directories are. Also quality, also network robustness. So it's really empowering the consumers with more information.
And I love the idea of empowering those consumers. I think we just talked about two of those regulatory and compliance initiatives getting pushed through. Both have an impact on Medicare Advantage, which is a space where we know the federal increases are only going to be about 0.9% next year, the smallest in quite a while. So they're going to now be required to measure and feed that MA plan finder.
When you're looking at some of these provider directories, we hear a lot about CMS accuracy scores, and you kind of just touched on it recently. But can you dive into a little bit of the actual, the methodology of how these directories are scored from an accuracy standpoint?
From what I remember of CMS and their secret shopper audit methodology from the MA audits that they did several years back, they pick 5 specialties, and just off the top of my head, I think it's PCP, pulmonologist, oncologist, ophthalmologist, cardiologist. Every provider who is associated with one of the specialties in their directory, and I think they probably do some type of zip code sampling first, maybe not zip code sampling. They select some sample of those providers, and it's in the hundreds, some type of statistically significant sample for that particular network. All of the addresses associated with all of those providers, and then they do a phone call for every single one of them. They're asking a bunch of questions of whoever's on the other end of the line. Is this provider in your organization? Is this provider at this address? Is this a phone number I would call for this provider to make an appointment? Is this provider accepting new patients? The specialty? And then for each one of those, there's some type of weighting of an error that is discovered, and then you deduct some points from that. And then I think there's an interesting thing, and I know there's some debate about this, about what gets included in the denominator, whether calls that are not complete are included in the denominator or not included in the denominator. So, but we have to see what CMS comes up with in the future. They may use that same methodology. They may adapt it, but that's what we know of how they've been doing it before, and how many payers have adapted that methodology to measure their own accuracy.
Sounds like just simple arithmetic.
It's not bad for off the top of your head.
So obviously the government is working on several different initiatives, MA Plan Finder being one of them, the CMS National Provider Directory, interoperability standards, all different initiatives that we're working towards to try to solve this problem. You've been front and center, and a part of a lot of these initiatives, Ron. Obviously, Defacto is doing a great job in trying to push this industry forward. Can you talk about a little bit about, your experience with CMS and working alongside CMS to try to drive this interoperability initiative forward? What are some of the things that we might be able to look forward to, and maybe what are some of the challenges or obstacles that we should all keep our eyes out for?
So one opportunity for anybody in the industry is to participate in the CMS health tech ecosystem. So lots of companies are pledging as either payers or as EHR vendors or networks. You can also just pledge as a friend of the ecosystem, and you can participate in the calls and join their Slack and have active discussions about all of these problems. So it's really neat that they're opening it up to the broader industry and broader community. Patient advocacy groups are even involved in offering to test some of these new builds that they're doing. And speaking of new builds, they will be releasing a version of the National Directory at the end of this month. Now, it's not going to include all of the it'll include some of the typical directory information that we talk about, like NPIs and names and addresses, perhaps phone numbers. But the focus is really going to be on the provider endpoints. So these are the digital endpoints that provider organizations will publish so that patients who want to access their data are able to do it and are able to find out where the endpoints are all in one place. So I know a lot of the big EHR vendors have pledged and are committing to publish their endpoints with enough provider hierarchy metadata so that a lot of these third-party apps supporting consumers will be able to hone in on the right endpoint and help the consumers find their information.
Yeah, I think, we were talking off camera for a little bit, but one of the really interesting parts of this conversation is I think there's a lot of conversation about a single source of truth. But is that really, realistic or possible, single source of truth? Or is the answer more interoperability is our goal here, right? It's almost like an information highway or like an air traffic controller that's sending data to the right place. And obviously endpoints are the first place to start there.
It's a good question whether source of truth is really going to solve the problem. Let me give the bear and the bull case for it.
Okay.
The bull case is that if you can get all of the data in one place, and if you've got a standard methodology to assess the completeness and the accuracy of it, then there are scale economies there to be able to do that all in one fell swoop in one place. You've got a choke point for the industry to gather all the data and look at all of it all together and come up with some type of judgment call on it. So if you can get everybody to participate and traffic or route all of their data through that choke point, then you've got a shot at solving for it. And if you define those standard measures of accuracy and completeness, et cetera. I think the bear case is, can you get all of the adoption and all the participation? Yeah, I'll just leave it there.
Yeah, you got to reach a tipping point. That's where it gets really hard. I do think starting with electronic medical records, I mean, you get 3, you've got 70% of the market with Epic's, Oracle, and Meditech. So I think that's really interesting. I love the thread on CMS, but I kind of want to talk about you, Ron.
Sure.
One of the things you mentioned is you've worked with about 150 providers. We've been in the space, and when we talk to groups that have partnered with you guys, whether that's in pilot or on a bigger scale, they're always extremely impressed. Like we talk to them, like Defacto has some of the best data and insights that we can get. What do you think that aha moment is for your partners? Like, what are you doing differently than a lot of the other partners in the market?
I mean, not that other folks aren't straight shooters, but we don't really have a filter and we just talk about things as they are.
You're in good company.
Hence the name, Defacto. It is what it is. It's helpful to be able to have some insights about their organization and their data ahead of time. So because we have access to these public APIs, there are some times when we have discussions with a health insurer and we'll present some insights to them like, oh, we see that you've got this number of cardiologists within these zip codes. And, this is, these 5 health systems within this geography are contributing 25% of your directory errors. And then we'll show them the top 5 lists and the prioritized list and show them some of the errors. And they say, wait, how did you get that information? Well, you're publishing it. The government mandated you to publish it. It's available. Anybody can look at it.
Yeah.
I'm just spending a little bit more time on it than a lot of other folks are. So that I think that's the aha moment that, oh, somebody's paying attention to the public data that we're publishing out. And I, as a payer, should probably get ahead of it and start looking at it myself and see what stories it's telling me.
Are you seeing them drive change once you bring this up? Like we talk about this, that's an accuracy question.
Yep.
And then there's this adequacy hammer and the difference between, okay, is your directory accurate? And then do you have network adequacy to go with that?
When I've been chatting with payers about it, it's mostly been about accuracy and also compliance of the API and is it functioning. But I do think the adequacy factor is playing a role. I have heard that many payers are, through some of their other solutions that they're using, are using this type of data to look at relative network robustness across the compliance measures, but also just is this network actually meeting the needs of my membership and my patient population and their conditions?
Really interesting insight here. People that pay closer attention to their data might figure something out about it.
Yeah.
Ron, if you look at the 30% accuracy groups versus the 70% accuracy groups, what makes them stand apart? If I were to guess which plans have the best directories or which ones have the worst, is there like a common thread or common theme that you're seeing?
There's a few things that I've seen. One is that some payers who are closer to their markets or to their provider networks, so think of regional plans or state blues, they're really, really close to their networks. They're on a first-name basis with probably their top 10 health systems. And I think there's a stronger feedback loop in there for them to be able to get better data. Here's an example. I provided some insights to a state blue, and they found out that there was this one health system that was contributing a vast number of errors into their directory. They provided some of that quantitative feedback, and also, hey, here's some actual errors. Like here's 100 of them. Like I want your opinion about them. They realized that the payer enrollment staff at the health system were using the CAQH portal incorrectly. Like they were picking the wrong option in the drop-down list. And so they were providing some education and constructive feedback. They went back and then they redid their processes, and a bunch of changes started to flow downstream. And so many of the errors that were coming originally from that health system just started to disappear.
Just simple change management.
Yeah.
That's super interesting. I've never heard that one before. Just like simple user error. The data is actually correct, but how you're using it and how you're implementing it into your systems is what's causing those issues. Any other insights like that? I think that's fascinating.
Yeah, I was going to say, I want to go a layer deeper.
Yeah.
Like, why are the bad directories bad? There's a big difference between 30% and 70%.
Yeah. I think there's one example on the payer side, and it's about roster ingestion. A lot of times the rosters will have flags for like, hey, you should publish this in your directory or you shouldn't, or, this provider is actually seeing patients on a frequent basis and by appointment. Some payers are taking advantage of that type of metadata, and many are not. And the ones who are not, and who are just over associating providers with locations, I think that's the biggest explanation of bad directory. Like that's probably responsible for the majority or the largest percentage of errors within their directory.
So there's an infrastructure problem and like a technology problem, plus the actual accuracy of the data itself. And without those two married together, you're not really going to see any huge improvements.
Yeah, there's the ingestion and the business logic around it. There's the mastering of the data within the payer's organization so that they can avoid bad data overriding good data. The challenge is that it crosses organizations. It's hundreds of provider organizations within their network. It's the payer's IT organization. It's probably multiple vendors within the payer. It's the folks who are giving data to the payer. It's the folks who are managing the repository. It's the folks who are making it available in a user interface for consumers to be able to search on, and the APIs. It's like 5 different vendors that they've got to manage.
It sounds unnecessarily complex. Like, I think these are the things that we're trying to simplify. And, my grandpa always said, keep it simple, stupid.
Yeah.
It's like, man, how do we just keep that simpler?
You hit on something there, Ron, that I think is so interesting. And, we hear about this all the time. We're a provider data management company, and folks always come to us and say, hey, my network, my directory is not as accurate as I'd like it to be. I'm looking for a directory accuracy solution. Great, no problem. But I can give you, I probably couldn't, but Defacto or someone else could give you accurate data. But if you don't have the right infrastructure to actually ingest and master that data, the next month, the delegate's going to send you the exact same incorrect roster. They don't know, and also they're probably sending the same exact roster to 10 different payers. And 10 of these addresses are relevant to you and 10 of them are not. And so we talk about this all the time. It's, you're focused on the symptom here, but the underlying root cause is what's causing a lot of the issues. And, I'm interested to hear your thoughts on, your experience with payers and, maybe who's done this well.
Yeah, there are several who have done it well. The payers who find the most challenges are those that are the product of so many different acquisitions, and they have to do the hard job of integrating all of those IT systems together. And I actually talked to a VP of one larger health plan that is the product of decades of acquisitions. But they actually, they made it a principle that when we bring this new subsidiary in, we're going to integrate all of the IT systems upfront. We're not going to wait on it. And they're having an easier time adapting to all of these directory requirements than the folks who have waited decades to be able to bring all of those systems together.
As you look at this space and you're having a lot of conversations, I think there's a benefit to that. Like, you're learning faster than many others in this provider data space. What are the challenges you're seeing the most, and what's your recommendation to solve for them?
Yeah, so I think there needs to be house cleaning on both sides of the industry, both on the payer side and on the provider side. On the payer side, there needs to be data mastery, a single source of truth, at least within their own organization. Then they've got a shot at solving the problem. Then when, Mitch, you give them the 99% accurate data, they can actually ingest it and it can persist over time. And then I think the biggest problem is solving it even further upstream on the provider organization side, because you've got also similarly have multiple repositories or sources of truth. Sometimes you've got a CRED system and a directory system in addition to an EHR, in addition to, an appointment
HRIS
platform
and everything else.
That's right. So you have to master all of that data. And they've often not had an incentive to go there and do that. Like they've been working on master patient indexes and mastering all of their patient data, which good, you should do that. You should also finish the job and do the rest of the data. Provider data is maybe not as important as the patient data, but it is very important.
Mitch brought it up, and it's like, it's kind of it's frustrating as I sit here and think about it, is Mitch is a health plan, you're a provider system. Unfortunately, in this case, Ron, you're going to give Mitch bad data. You send him bad data from Mitch's delegated network to him. We know it's bad, and we hear from almost everyone we talk to, it's been flagged as bad. We go tell the provider system it's bad. Next month, guess what comes to us?
Same bad data.
It's not clean data, that's for sure.
Yeah.
It's bad again. And we know that provider group, like Mitch said, is sending that to 5, 6, 10 plans every single month with the exact same problem. It's frustrating, but I don't necessarily have the solution.
I mean, the solution exists today. I mean, the technology exists, like with AI today and with master data management and with survivorship logic. You can ingest the same data over and over again, and all it takes is one provider relations employee to say, you know what, this location is not relevant to me. And now every single time after that, an AI should be able to see, hey, I know that this location is not relevant to me, or to flag it for somebody to confirm it's not. But at least that's, you have a check in place before you overwrite the data.
Let's piggyback off of that. If you can solve it once as upstream as possible, it has a multiplying positive impacts across the entire industry. Some of the health systems have good data. You're just not giving it to the payers. Like they're publishing it within their own directories, because I've audited some of those directories. And they're not perfect, but they're a whole lot better than the payer directories. Like that's the good stuff. Like payers should go to their health systems, their biggest health systems, and say, give me the top shelf data. Give me the good stuff.
Give me the good.
Yeah.
So I don't want to give you the business idea, but maybe that's the actual solution is, give a payer a tool that can then go farm all the directories off that they serve.
Why do you think that is? Like, why do you think they have great data and they're just not giving it?
Because they're solving for two different jobs. On the marketing side, they're solving for the job of, I want to get the best data and spread it as wide as possible so that consumers and patients know how to get in contact with me to be able to book an appointment. You've got health systems who are, not all, not most, but some already. Nobody's mandating them to do this, but they're publishing appointment availability for providers and slots so that consumers and third-party apps can figure out, when can I make an appointment with this provider? Is any payer getting that data? Maybe a handful, probably not most. So the marketing department and the patient access department has a huge incentive to get the data right and spread it as widely as possible. But that data is not going into the payer enrollment department. The payer enrollment department's job is to get providers in network so they can submit claims, and that's it.
Yeah.
I mean, I don't want to oversimplify it. I don't want to, like, payer enrollment folks are miracle workers, and they know how to navigate the intricacies of all of the payer enrollment processes, and that's a really hard job. I entirely empathize that, they're not being told, and they're often not being given access to the right data to make it available. But there needs to be a dialogue internally within the provider organizations to solve for this.
I wanted to, go ahead.
Yeah, you'd think that there's like aligned incentives here. If a payer publishes in their directory your appointment booking link, it drives more appointments to your provider. And so the private provider, meanwhile, should then reciprocate and say, hey, here's my updated data. I know that, if you have an updated directory and it's accurate directory, it'll drive more patients to me.
100%. Because so many consumers start their journey to find care in a payer's directory because they want to make for sure that a provider's in network because they've had to deal with out of network. Yeah, I know. As sure as you can be.
Do you think consumers are going more to their local health systems directory or their payer's directory?
I think consumers are starting with Google, or now perhaps with ChatGPT or with Perplexity or
That's a good point.
With Claude. Those guys might be starting to scrape some of this data too to make it available. In terms of payer directory versus health system directory, I think it depends on whether the patient has a preconceived notion or has a pre-existing relationship with a health system like a Memorial Hermann within Houston. They want to stay, within that system because they want all of their EHR data to talk together. But others, who don't have that relationship, a lot of times they start with the payer directory because they just want to make sure their provider's a network.
Think about the last time you guys needed care. Where did you go? How did you find it?
I go to my payer's directory.
Do you?
Yeah.
That's a provider data dork through and through. I Googled it. Last time I needed care, I Googled it. Actually, what really happened is my wife sent me a picture of a business card and she's like, will you just call this doctor?
I guess I Google it, but then I go to my directory and I see if that provider
Confirm it,
yeah.
Ron, hopefully you don't need care. You're a human specimen.
Google payer directory, and then I double check the payer directory by checking their API and also my data sets. Yeah.
Okay, not the average healthcare consumer.
Yeah.
So Ron, maybe we'll end on this question then. We've talked a lot about AI, maybe scraping some of these directories, talk about CMS and their National Provider Directory initiatives. Seems like it's encroaching a little bit on some of the work you're doing at Defacto. Obviously, you've been ahead of the game the last 5 years. Where do you go next with Defacto?
If CMS is successful getting all of the endpoint data, all of the plan data, and they clean up all of the address information, good on them. And that is going to raise a C level for the entire industry. And I and everybody else is going to be able to build on top of that. There are so many things that we can do with that. And for so many of the different actors or parties within the healthcare industry, payers, providers, consumers, everybody, employers, I'm excited when all this data becomes complete and accurate and available, because we're going to be able to build, in-network provider search better. We're going to be able to build plan shopping better. Employer groups are going to be able to assess approximate costs of care for their entire staff better. I'm excited about more dynamic provider networks that can adapt to the needs of their member population. Because as these Real Health Provider Act and other regulatory and legislative requirements come into play, I think payers are going to want to provide a more adaptive, dynamic network for their member population. And so that's going to require faster credentialing, faster enrollment, more transparent enrollment. So, all of those things we're going to be able to build off of that solid foundation of better data.
I love that. I will never get off this soapbox, but one of my favorite companies in the fintech space is Plaid. They lay that infrastructure that connects all these disparate siloed databases that is historically super siloed and protected. And now you can build on top. Now you have Venmo on top. Now you have Zelle on top. Now you have Rocket Mortgage on top. You can send money anywhere you want. 10 years ago, that was not the case. And it really exploded this industry. And to your point, if we can lay that infrastructure through CMS or through Defacto or maybe some of the work that we're doing, now you can do a lot cooler stuff on top of that and really start to drive innovation.
Yep, 100%.
Hey, let's do the right lightning round. Let's start with healthcare, the topic we've been talking about. We're at a period of just wild innovation right now, and I think there's a lot of promise there. But what's your one wish for healthcare?
I guess we've already talked about cleaning data upstream and things like that.
It doesn't count.
It's a provider data dork through and through.
I'm going to get a little bit nerdy.
Please.
I'm a big fan of identifiers. I think it's time that we have an industry accepted network identifier, because you've got a lot of same sounding plans and networks. And I think having a true identifier that both the payers and the providers and patients can use will help us all make better decisions.
So it's at the plan level, like the network or product level?
So there's often a one-to-many relationship between a network and then the multiple plans that adopt that network. So yeah, I think at the network level because a lot of times the directories themselves are at the network level, and I think the Google searches and the AIs and ChatGPTs will probably want to search that network level too.
Another interesting piece here is identifiers at the, I'll call it person level, not necessarily practitioner or provider level, because we have NPIs, but not we have a whole new class of, let's call them practitioner types between caregivers or, doulas that, don't necessarily have NPIs, might not be credentialed entities, but they're hugely important to the space. How do we pay claims? How do we show them in our directory? And how do we have some sort of identifier for them? Super interesting.
So I think all of those guys can get NPIs, but to your point, it looks like CMS wants to go past just identifiers there. They want to get to like actual identity. So that's why they're pushing Clear and ID.me and all those things, even for providers as they're submitting data into the national directory.
Ron, what's on your nightstand right now?
Right now it's Hamilton Helmer's 7 Powers. So if you're a fan of the Acquired podcast, they often refer to that. But a book, an author that has been on my mind lately is author's Tracy Kidder, and he just passed away, I think, yesterday. He's famous for the book The Soul of a New Machine, which is about like the early mini computer days, so Data General and digital DEC, and how they were trying to create the next generation of computers. It was published in 1981, but it reads like something that could have just been published a few years ago. So, like anybody in the tech space that wants to just read a really good storytelling about the early days of computing, it's an amazing book. Tracy Kidder also published a Truck Full of Money, which is about the founding of CAQH. Yeah.
Got a lot of books on the nightstands of the provider data dork community. I'm just waiting for someone to be like, it's just a box of Oreos. What's the best advice you've ever gotten?
The best advice?
Or the worst?
The best advice that I've gotten is to fall in love with a problem and not fall in love with the solution. And because, technology will come and go, approaches for solving problems will come and go, but problems will, like this one that we're trying to solve for, last for a very long time. And so to finally solve these problems, you have to love, I know it sounds weird to love a problem, but you have to fall in love with the problem.
I think that's a beautiful place to end, because I think we've found a problem that we all love, and this provider data dork community loves and knows that we have to change something and there's better ways to do things. So Ron, thanks for joining us. We appreciate it.
Thanks,
for having
Ron.
me.
Appreciate it.